For 11 years, I kept the lights on at a regional hospital network. Not literally, that was the facilities team. But every server, every network switch, every piece of medical equipment that talked to another piece of medical equipment, every nurse's workstation that pulled up a patient chart at 2 a.m, that was me. I was the IT systems manager for Mercy Regional Health, 3 hospitals and 7 outpatient clinics across 2 states, 4,000 employees, and a patient database going back to 1,987. I knew that infrastructure the way a surgeon knows anatomy. Every weak point, every workaround, every legacy system we were nursing along because replacing it would cost more than the CFO wanted to think about. They let me go on a Wednesday. The CFO's nephew had just finished his master's degree in information systems. He was 26 years old. He had never managed a production environment in his life. But according to my boss, the VP of operations, a man named Gerald who had never personally rebooted a server, the nephew had fresh ideas about modernization, and the hospital was moving in a new direction. I asked Gerald what direction that was. He said, leaner, more agile. I asked him what that meant for a hospital IT infrastructure supporting active patient care. He looked at his desk. Effective end of the month, he said. We'll need your access cards. I packed my laptop bag. 11 years of institutional knowledge walked out the door with me. I don't think Gerald understood what he had just done. I don't think he understood it until about 6 weeks later when the whole thing started coming apart. But I'm getting ahead of myself. Let me tell you how we got here. I started at Mercy Regional back when the network was held together with duct tape and goodwill. 3 different IT vendors had walked away from the contract before me, each one citing complexity beyond the scope of the engagement. What that meant in plain English was that the hospital had grown faster than its infrastructure. Nobody had documented anything properly, and the systems were layered on top of each other like geological strata. You couldn't touch one thing without understanding how it connected to 6 other things. Most of those connections weren't written down anywhere. They lived in the heads of the people who had built them, and most of those people had moved on years ago. I spent my first 18 months just mapping everything, not because anyone asked me to, because I couldn't sleep at night not knowing what I was responsible for. I built documentation that didn't exist. I created runbooks for failure scenarios that had never been planned for. I established relationships with every department, head nursing, pharmacy, radiology, the OR, the lab, so that when something broke, they called me directly instead of waiting for a help desk ticket to work its way through the queue. In a hospital, time matters. A radiology system going down at 7 a.m. during a shift change is not the same as a radiology system going down at 2 p.m. on a Tuesday. The stakes are different. The urgency is different. You have to understand the clinical environment, not just the technical one. Over 11 years, I built something I was genuinely proud of. Uptime across the network averaged 99.7%. We had one major incident, a ransomware attempt in year 6, that I caught before it propagated because I had monitoring alerts set up that the previous team had never bothered to configure. We passed every Joint Commission inspection. When the Epic electronic health record system rolled out across all 3 hospitals, I managed the implementation while simultaneously keeping the legacy systems running, which is exactly as difficult as it sounds. The Epic vendor's own project manager told the CFO it was the smoothest hospital rollout he'd seen in 15 years of doing implementations. None of that was in the room when Gerald told me I was being replaced. The nephew's name was Tanner. I met him once, briefly, in the hallway outside Gerald's office on my second to last day. He was carrying a MacBook and wearing a fleece vest. He shook my hand and said he was really excited to bring some innovation to the space. I smiled. I asked him if he'd had a chance to review the infrastructure documentation. He said he'd skimmed through it over the weekend. I told him there was a lot of it. He said, I learned fast. I wished him luck and meant it more sincerely than he probably realized. I want to be clear about something. I did not sabotage anything. I did not leave booby traps. I did not set timers or bury logic bombs or do any of the things people always suggest in the comments of stories like this. What I did was complete my handoff documentation thoroughly and professionally, submit it to Gerald's assistant on my last day, and walk out. The documentation was accurate and comprehensive. If Tanner had read it, actually read it, not skimmed it, he would have had a fighting chance. The first call came 43 days after my last day. It was from Linda, the director of nursing at Mercy's main campus. Linda and I had worked together for 8 years. She was one of the smartest, most no-nonsense people I had ever met in healthcare administration, and she was not someone who called to chat. I need to ask you something off the record, she said. I told her to go ahead. Our nurse workstations have been throwing authentication errors since Tuesday. Half the night shift couldn't pull charts for 40 minutes last night. Tanner says it's a known issue and he's working on it. What I want to know is whether this is actually fixable or whether I should be escalating to the CNO. I asked her a few questions. She described the symptoms. I recognized it immediately. It was a token refresh issue with the Epic integration, something that happened periodically when the underlying domain controller's clock drifted more than 5 minutes from the Epic server's clock. It was in my runbooks. Page 47, section 3. The fix took about 8 minutes once you knew what you were looking for. I told Linda what it was. I told her which runbook to point Tanner to. I told her if he couldn't find it or couldn't follow it, she should escalate, because authentication failures affecting chart access was a patient safety issue, not just an IT inconvenience. She thanked me and hung up. 30 minutes later, Tanner apparently found the runbook and fixed it. I know because Linda texted me. He fixed it. Thanks. You probably saved him 3 days of flailing. I put my phone down and went back to my life. I had started consulting by then, picking up project work with a couple of healthcare IT firms I'd networked with over the years. The money was better than my salary had been. The stress was considerably lower. I was sleeping 8 hours a night for the first time in a decade. But the calls kept coming. Not from Linda every time, from different people. The lab supervisor at the North Campus, asking why the instrument interface had gone read-only. The pharmacy director, reporting that the automated dispensing cabinets were not syncing with the EHR. The radiology lead, telling me that the PACS system had been throwing timeout errors for 3 days and imaging turnaround was backing up. I helped when I could. I pointed people to the documentation. Sometimes I walked them through things over the phone because it was faster than explaining where in a 400-page runbook to find the answer. I did this because these were clinical systems. Real patients were attached to the downstream effects of these failures. I wasn't going to let my irritation with Gerald's decision translate into harm for someone lying in a hospital bed. What I was watching, though, was a pattern. Tanner was not incompetent in the way that someone with no skills is incompetent. He was incompetent in the specific way that someone with theoretical knowledge and no operational experience is incompetent. He understood concepts. He could not execute under pressure in a complex, interdependent production environment. He was also, based on what people were telling me, resistant to reading the documentation I had left because, and I heard this secondhand from 3 different people, he thought it reflected outdated approaches and he was planning to redesign the architecture from scratch. I remember sitting with that information for a while. Redesign the architecture from scratch. In a live hospital network, serving active patients, with 11 years of organic interlocking dependencies that he had not yet fully mapped, by himself. I did not say anything to anyone, I just waited. The serious incident happened on a Friday evening in what would have been my 4th month out the door. I know the exact timing because Linda called me at 6:47 p.m. while I was making dinner. We have a major outage, she said. Her voice was controlled in the way that people in healthcare learn to be controlled when things are going badly. Controlled doesn't mean calm. It means they've been trained not to panic out loud. Epic is down across all 3 campuses. ER is on paper downtime procedures. The OR had to delay 2 non-emergency cases. We can't get Tanner on the phone. I put down what I was cooking. How long has it been down? 40 minutes. Is this a full application outage, or is it the network layer? We don't know. Tanner's been talking about migrating something this week. One of the nurses in IT support told me he was doing something with the VLAN configuration. I closed my eyes for a moment. VLAN reconfiguration. On a Friday evening. In a live hospital network. And I was now fairly certain of this without testing it in a staging environment first, because I knew for a fact that Tanner had been pushing Gerald to decommission the staging environment to cut costs, and Gerald had approved it 3 weeks ago because Tanner had told him it was redundant infrastructure. I want you to understand what a hospital EHR outage means in practical terms. It means nurses are handwriting medication orders. It means physicians are working from memory and paper charts for patients whose histories are normally at their fingertips. It means pharmacy is manually verifying dispensing records. It means the lab can't receive electronic orders or return results through the system. It means every process that has been digitized over the past 15 years is suddenly being done the way people did it in 1995, except that the people doing it were trained in the digital workflow and are now operating under stress in an unfamiliar manual one. In an ER on a Friday night, that is a dangerous situation. Where is Gerald? I asked. He's been contacted. He's asking if you'd be willing to come in. There it was. 43 days of calls I'd fielded informally. Months of watching the slow degradation of something I'd built. And now, on a Friday evening, with a hospital network down, and a 26-year-old with fresh ideas nowhere to be found, Gerald needed me to come in. I told Linda I needed 20 minutes to think about it. She said she understood, but that 20 minutes was a long time right now. I told her I knew. I called my wife. I'm not going to pretend I made this decision alone or that I was above needing to talk it through. She listened to the whole thing and then she said, "You're going to go. You know you're going to go. The question is what it costs them." She has always been smarter about these things than I am. I called Linda back. I told her I would come in, but I needed to speak with Gerald directly before I set foot in that building. She put me on hold for 90 seconds. Gerald got on the line. He sounded like a man who had spent the last hour learning what the phrase patient safety incident means when it appears in an after-action report that goes to the board. He said, "We really need your help here." I noticed he did not say please. I also noticed that he did not apologize. I filed both of those observations away and let them go because this was not the moment. I told Gerald I would come in and stabilize the network. I told him my consulting rate was $250 an hour and that I would need that in writing before I walked through the door. I told him that if the situation required more than a single incident response, we would need to have a separate conversation about a longer engagement, and that conversation would involve different numbers. I told him I would be there in 30 minutes. He agreed to everything. I think he would have agreed to anything. I later learned that the hospital's general counsel had already been notified and that the words regulatory reporting had been mentioned twice in the 40 minutes since the outage began. I drove to the main campus. I showed my old ID to the security desk. They hadn't deactivated it yet, which told me something about the state of Tanner's offboarding protocols, and I went straight to the server room. What I found took me about 4 minutes to diagnose. Tanner had attempted to restructure the VLAN segmentation that separated the clinical network from the administrative network. His intention, based on the changelog I pulled up, was to reduce broadcast traffic and improve performance. It was not a bad idea in theory. In practice, he had misconfigured the trunk port on the core switch, which had severed the communication path between the Epic application servers and the database tier. The whole system was intact. Nothing was corrupted. It just couldn't talk to itself. I rolled back the change. The network came up. Epic restored. I watched the authentication requests start flowing across the monitoring dashboard, like water finding its level again. From the moment I sat down at the terminal to the moment full application availability was restored, it was 22 minutes. I sat there for a moment after it came back up. 11 years of knowing exactly what every light on every panel meant. 22 minutes. I wrote up a full incident report, documented the root cause, documented the remediation steps, and documented 3 additional configuration risks I identified while I was in there. Things Tanner had changed or was in the process of changing that had not yet caused failures but would. I left the report on Gerald's assistant's desk with a sticky note that said my invoice would follow by email. Gerald called me the following Monday. He had clearly rehearsed the conversation, or possibly had HR coaching him through it, because the opening was more structured than his usual meandering style. He said the hospital wanted to discuss a transitional consulting arrangement. He said they valued my expertise. He said they wanted to explore bringing me on in an advisory capacity, while they, and this is the part he clearly found difficult to say, while they evaluated the current IT leadership situation. I asked him what that meant for Tanner. He was quiet for a moment. Then he said Tanner had been moved to a project coordination role. I asked what projects he would be coordinating. Gerald said that was still being determined. I told Gerald I was open to a consulting arrangement. I gave him my terms. The hourly rate I quoted was 40% higher than what I'd asked for on Friday night, because Friday night was an emergency rate and an ongoing advisory engagement was a different kind of work. I told him I required a written scope of work, a defined decision-making authority so that my recommendations could not be overridden without documented sign-off, and a clause that any infrastructure changes above a certain threshold required my review before implementation. I also told him the staging environment needed to be rebuilt before I would sign off on any further production changes. He said he needed to take that to the CFO. I told him to take his time. I was not waiting by the phone. The contract came back 4 days later. Every term I had asked for was in it. The staging environment clause was in there. The decision authority clause was in there. My rate was in there. There was also, which I had not asked for but which someone in legal apparently felt was prudent, an indemnification provision that protected me from liability for any incidents that occurred outside the scope of work I had approved. I signed it and went back to work. The thing about institutional knowledge is that it doesn't look like anything from the outside. It looks like a middle-aged guy in a data center looking at screens. It doesn't look like 11 years of knowing why the pharmacy integration has a 15-second timeout that has to stay at 15 seconds because of a quirk in the dispensing cabinet firmware from 2014. It doesn't look like knowing that the OR's backup connectivity route runs through a secondary switch that nobody else remembers exists because it was installed during a construction project and never properly documented in the original diagrams. It doesn't look like anything until the moment it's gone, and then it looks like a hospital on paper downtime procedures on a Friday night. I am not telling this story to be cruel about Tanner. He was young and he was overconfident, and he was put in a position he wasn't ready for by an uncle who wanted to do him a favor and a VP of operations who didn't understand what he was approving. That's a bad combination, but it's not a rare one. I've seen versions of it in every industry I've ever worked adjacent to. The favor recipient always pays for it eventually. Tanner paid for it faster than most. What I want you to take from this is something simpler. Gerald made a business decision based on factors that had nothing to do with operational competence. He looked at my salary and Tanner's salary and saw a number. He didn't see the 11 years of context that salary was actually paying for. He didn't see the 2 a.m. phone calls I'd fielded without billing for them. He didn't see the ransomware attempt I caught in year 6. He didn't see the epic implementation that the vendor's own team called the smoothest they'd ever seen. He saw a line item. Some decisions announce their consequences immediately. Some of them take 6 weeks. Some of them take longer. But the consequences come. I've been back at Mercy Regional in an advisory capacity for 8 months now. My actual office is a consulting firm downtown that I joined as a partner 6 months ago. I do hospital IT advisory work for 4 health systems now, and Mercy Regional is one of them. I work fewer hours than I did when I was their employee. I bill for every hour I work. I have not had a 2 a.m. call that I didn't get paid for since the day I left. Gerald still works there. We have a professional relationship. He is careful around me in the way that people are careful around someone who watched them make a very expensive mistake and didn't say, "I told you so." I have not said it. I don't need to. The staging environment is back online. All production changes go through my review process. The network is running at 99.8% uptime, slightly better than when I was an employee, actually, because the consulting contract gave me leverage to push through 3 infrastructure upgrades I'd been asking for as an employee for 4 years. And Tanner? Last I heard, he was coordinating a waiting room renovation project at the North Campus Clinic. I don't know how that's going. I hope it's going fine. I genuinely hope it's going fine.